Well, good morning, everybody. I'd like to welcome you all to Family Medicine Rounds, the October edition. This time we're looking at using data in quality improvement for FMRSP projects and more. We have two great speakers. First is going to be Maddie Venables. And Maddie has a pre-recorded session that she's going to be sharing with us, and then we'll have a time for question and answers after. And then Dr. Peter Tanuseputro is going to be talking as well, and he will be giving a live presentation. So if you're new to Rounds, welcome. We have an exciting lineup all year that I think you'll find very enjoyable. My name is Doug Archibald, and I'm the Director of Research for the Department of Family Medicine. And it's a great privilege for me to be able to introduce our two speakers today. So I'll start off with Maddie. And Maddie completed her PhD in biology here at the University of Ottawa. She's an academic research advisor for the Department of Family Medicine, where her primary role is to provide support to faculty and residents with the completion of their FMRSP projects. She's also a regional coordinator of the Ottawa Primary Care Network called the Ottawa Practice Enhancement Network, or OPEN, and works along with Simone de Rouge to support primary care practices in achieving their quality improvement goals. So without further ado, I'll hand everything over to Maddie, who will share her presentation. And then, as I said, then we'll have a chance for probably about 5 minutes or so for questions before our second speaker.
Bonjour à vous et merci, Dr. Archibald, pour l'introduction. Je vous apporte ce sujet de présentation aujourd'hui comme but de vous encourager à utiliser vos données médicales électroniques en pratique pour que vous puissiez accomplir vos activités d'amélioration de la qualité des soins, vos projets d'érudition et vos projets de recherche. Je ferai la présentation des premiers diapos en français. Ensuite, je changerai en anglais. Si jamais vous avez des questions qui vous viennent en tête lors de la présentation, je vous invite de bien les noter pour qu'on puisse avoir une belle discussion par la suite. Je n'ai aucun conflit d'intérêt à vous rapporter aujourd'hui. Alors, je pensais qu'on pourrait commencer la discussion avec les différents défis qu'on confronte lorsqu'on essaie d'accéder les données pour accomplir des activités en pratique. Alors, certains défis qui me viennent en tête, c'est que nous sommes limités par l'accessibilité des données par les vendeurs des systèmes des données médicales électroniques. Alors, habituellement, en pratique, on a accès à l'avant-plan, le front-end, qui nous donne accès aux données au niveau du patient, mais non au niveau des prestataires des soins. Et si jamais on voulait faire l'extrait des données au complet, habituellement, on fait face à des frais qui sont parvenus par les vendeurs des différents systèmes de données médicales électroniques. Autre défi qui me vient en tête, c'est que nos données ne sont pas nettoyées et ni standardisées, qui fait difficile si on veut comparer notre performance à celui de nos collègues ou même à d'autres pratiques dans la région au niveau provincial et national, surtout que les pratiques utilisent des différents vendeurs qui utilisent tous des différents formats pour enregistrer les données de vos patients. Et finalement, je voulais toucher que nous sommes limités par notre temps et les ressources à notre disposition pour accomplir nos activités en pratique. Alors, je vais vous proposer une solution aujourd'hui ou une option alternative que vous pouvez adopter si vous voulez recevoir du support à accomplir des activités en pratique. Et cette solution, c'est RASPO, qui est le réseau d'amélioration des soins primaires d'Ottawa, ou OPIN, the Ottawa Practice Enhancement Network. And this network, it's a learning collaborative comprised of primary care practices in Ottawa and surrounding areas, focused on strengthening primary care. So OPEN supports its members to achieve their QI or quality improvement goals, research, or even scholarly goals. And these services can include helping you formulate your research question, try to identify a gap in your EMR data, even offering practice facilitation to implement and change in your practice, tracking and monitoring this change to see if there's an improvement that actually occurred. And all these services are at no cost. So these are free. And there's different levels of engagement for primary care practices within Open. And I'll just briefly touch on these. So there's 3 tiers. So if we look at the basic tier, this is where you can join Open and receive a newsletter on Open's activities with primary care practices in the region. So your colleagues, what's going on in terms of quality improvement, research and scholarly. And if we move on to tier 2, this is where you could contribute your EMR data, get it clean and standardized by the Open team, and then receive a standard EMR report reporting on standard quality indicators and chronic diseases such as diabetes, COPD, hypertension, and see your practice in comparison, see your practice standing in comparison to other practices in your region, provincial, and at the national level. You could also have access to the DPT, which is a data presentation tool. It's an online platform where providers could go in and access this clean and standardized data from their own search queries. And if we move on from tier 2 to tier 3, the gold membership here, you still contribute your EMR data, but at this point you're engaged in actually implementing a quality improvement activity or research or conducting a scholarly activity. So you would be sitting down with Open, receiving support, tailored EMR data analyses and reports on the quality indicators that you're prioritizing for your activities. And we would follow you throughout the whole activity as it progresses, tracking its progression so that we can see if there is an improvement that occurs at the end. And how Open can actually provide a clean and standardized EMR data from different EMR vendors, it's because it's part of CIPSEN, which is the Canadian Primary Care Sentinel Surveillance Network. And this is a network of primary care networks. So there's 14 primary care networks across Canada. Open is one of them. And it currently has about a little over 1,700 family physicians that are part of this national network, and they care for almost 2 million Canadians. So you can see how this would be a very rich set of data, of patient data, to be able to do some quality improvement research and scholarly activities. And CIPSEN has validated case definitions for 8 chronic diseases, and as well as standardized the processes for cleaning and standardizing the data. And when I say cleaning and standardizing, it means it could be functions like making sure the units are the same throughout. So everything is measured in pounds or kilograms, that the coding is the same. So using ICD-9 codes. It could also mean looking at the fields, making sure that the information is in the correct tables. And if we look more closely at Open specifically, how the EMR data gets extracted, cleaned, processed, standardized, and then fed back to the practice in reports and patient lists, we can look at this diagram. So this would be applicable for tier 2 and tier 3 of the Open membership, where you're actually contributing EMR data and getting a report back on your performance. So you have, sorry about that. So we have your practice here. The EMR data gets extracted into a secure and safe server. The EMR data that extracted is de-identified. It uses all kinds of privacy algorithms to make sure that re-identification is not likely to occur. Once it gets clean and standardized, it feeds back to Open. And this is where Open can feed you standard feedback reports or tailored EMR reports on quality indicators that you wish to address and prioritize in your practice. Based on those indicators, we can actually provide you with a list of patients meeting that criteria for targeted interventions. And you can re-identify that list in the practice. And aside from open, you can have understand your performance in comparison to other practices within your region. At the provincial level, they're currently getting together. There's 6 primary care networks within Ontario. They're coming together to form their own network under Simpson. And then we have the National Simpson database. And the information that is contained in the EMR of family physician is largely untapped source of data on patients. And we can use it for multiple uses, including their quality improvement, even FMRSP projects for residents in the Department of Family Medicine, for scholarship and research activities. And here I listed the 8 case definitions that are validated by Simpson. And when I say they've been validated, and it means that they not only use the information, the health condition table, but they use different tables, such as medication, lab results, so on and so forth, to identify those patients that fit under each of those health conditions. So if we look at quality improvement for the multiple uses of EMR, if we look here, there's the 6 domains reported by the Health Quality Ontario. We can look at different focus areas. So those relating to safety, so trying to reduce polypharmacy or potentially inappropriate prescription in elders. There's quality improvement areas relating to effectiveness or timeliness, trying to reduce appointment times, next day, same day appointment, efficiency, patient-centered, and trying to improve equitable access to services. And the whole goal is to increase patient satisfaction or productivity or even provider satisfaction and reducing operating costs. And you can line up your potential benefits in the quadruple aim too. So why do we undertake quality improvement? So if you do undertake quality improvement and receive support from Open, it can help you help residents accomplish their QI and FMRSP projects to meet the requirements of the residency. Open can support the faculty as in co-supervising those QI and FMRSP projects. And also we can help, if we look at a bigger scheme of things, Open can support primary care practices respond to expectations from the ministry, for example. So for those family health teams that need to produce and report quality improvement plans, there's a CFPC, so Open aligns very well with the Practice Improvement Initiative launched by the CFPC, where they want practices to be research and quality improvement ready. And there's also the CPSO New Quality Improvement Program, which is replacing the random peer assessment, where primary care providers are encouraged to participate in this program and produce a practice quality improvement plan. So these are all areas that Open can support you in creating those reports. So the role of Open with the practice report. So if we look at the Tier 2 and Tier 3 memberships, you can be provided with standardized reports or tailored reports on quality indicators that you wish to address in practice. It could be screening of diabetes, a screening of different cancers, a continuity of care. There's a lot of possibilities. And based on the quality indicators that you select, then we can tailor those reports for you. And if we look more closely at an example of your practice report, what it could look like through Open. Oh, before I get to that, so these are examples that primary care practices that are members of Open have decided to address last year. So those was the prevalence of different chronic conditions such as chronic kidney disease, COPD, dementia, depression. There was also around safety, so trying to address polypharmacy, diabetes, different billing codes, and seeing if those folks that are diabetics had eye exams and continuum of care. So the list this is not stringent. We can definitely look at different quality indicators if you have other areas you would like to focus on. And Open will work with you to try to identify those quality indicators that are not currently captured in your EMR, but that you might wish to report on and see their current standing, such as we could add an EMR, help you add an EMR stamp in your EMR database, or distribute a form or other resources. So one way of identifying a gap is within the report. You can see here, this is on medication safety. So individual potential inappropriate prescriptions that are prescribed for those over 65 years of age. So we would give you a report that would be similar to this for different prescriptions here. So you would have the interquartile range of the whole network and your position. So this would tell you how well you're doing in comparison to other practices within the network, and it could help guide the selection of your quality area that you might wish to address. Open can play a mentorship role. So again, in the co-supervision of trainees, co-supervisions of residents in QI and FMRSP projects, we have developed a quality improvement workbook that you could use as a resource to complete your quality improvement activities. So Open has adopted the model of improvement from the Institute of Health Improvement, as well as the Health Quality Ontario Quality Improvement framework here to implement or to conduct quality improvement activities in practice. And if we move outside of quality improvement, so there's the FMRSP, like I've mentioned before. So you could ask through Open for a cut of the national Simpson EMR data, and the possibilities are endless here. You could use the data to conduct population health and epidemiological studies, such as like doing an intervention, evaluating outcomes, evaluating the rates of treatment of the diseases, or the prevalence of a disease, even the burden of an illness and multimorbidity, health services, so resource utilization, health informatics, and apps. So you could try to develop and test an apps using the Simpson National EMR data, or develop patient education apps. So the possibilities are endless. So through Open and having access to 14 different primary care practices contributing de-identified EMR data to a central national database, you could use that data to inform some of your activities. And these are just examples of a few studies or research activities that were conducted using Simpson EMR data at the national level. So trying to see if there's adherence to the Choosing Wisely Canada, try to reduce overprescribing and overtesting, or here hospitalization as admission and emergency department use for those that are diabetics. So linking the Simpson EMR national data to ICES, so the Institute for Clinical Evaluative Sciences. And outside of quality improvement and the FMRSP, there's also scholarship and research. So usually there are different levels or potential levels of involvement for family physicians in scholarship and research. And here I provide a framework adapted by Pimlet and Katz in 2016 to describe the potential areas that family medicine physicians might engage with research. So research is defined as the generation of generalizable knowledge, whereas scholarship is more perceived as continuing to learn and keeping up to date with the new ideas that are generated from research and systematically evaluating those new ideas. So here I'm just providing you with a few examples how family medicine physicians are engaged in research. And these range from doing literature reviews and reading articles, all the way to doing case reports, so trying to identify new illnesses, or quality improvement that we discuss throughout this presentation to practice-based research networks. So involvement of family medicine physicians in these networks, which open is one. So this is part of being involved in research and scholarship. And these types of involvement are you're able to get involved in these types of research engagement activities at the 3 different membership levels of open. So I'm just going to end with noting some of the strengths and limitations for primary care practices and providers to join open, to use their EMR data to conduct quality improvement, research or scholarly activities. So open can efficiently extract your EMR data for the purpose of planning and setting up your priorities, identifying list of patients for targeted interventions, monitoring the progress of the quality improvement activities, and to help you with reporting to the ministry and other organizations. But you need to realize that because open does rely on coded EMR data, the data availability is mostly limited to coded fields. So we don't extract open text fields, so it's only coded fields. And the quality of the reports go hand in hand with the quality of the EMR data entry. So sometimes primary care practices have used the EMR reports as a quality assessment measure, trying to improve their data entries at the practice level. The quality reports are usually available 4 to 6 weeks. So once we initiate EMR extraction, it takes 4 to 6 weeks for us to get the data and analyze it and then return it to you. And then to be able to have access to those standard or tailored EMR reports, your practice must be a member of the open network or at least one of the providers in the practice. So I share here some of the testimonies that our open practice members have shared with us, and like some here, we've helped them with addressing why patients were or were not joining their online portal, so identifying barriers here. So I'll leave this to you to read. And open is governed by a steering committee, and we have various clinical and experts and quality improvement experts, primary care leads. The chair of the department is part of the steering committee. So we're lucky to be able to have such very informed individuals to support our primary care providers. So I welcome you to contact us if ever you are interested in hearing more or joining the Open Initiative. And we're currently constructing a website that you'll be able to access even more information about Open. Thank you very much.
Thank you very much, Maddie. At this point, we've probably got about 5 minutes for questions. If you take a look at your chat, you can see that already we have a very active conversation going. But I was wondering, Maddie, if maybe you could start addressing some of these questions. I think Simone has been attempting to answer some of them, but I mean, I guess maybe we can even start with Francis around data cleaning. Is this a manual or automated process? And I think Simone has said that generally it is an automated one. But maybe you could look at the next question. Updates on Open's ability to access data from Epic.
Well, that's a really good question. Right now, we are in discussions with the leaders at the Ottawa Hospital to try to establish an agreement to access the data in Epic. But right now, we are unable to extract data at Epic. But SSMF has started developing the framework to be able to extract data from Epic, because they have to standardize the processes and make sure they know how the data dictionary is built behind the EMR vendor. So we are in preparation to be able to accept Epic EMR data.
Thank you. And I think that maybe addresses Gary Viner's question as well. Lise had asked a question about compatibility of open with all major EMR softwares, and Simone has addressed that.
Yes, so it's,
sorry, go ahead.
Yeah, it's Simone. Is gaps with a general approach on dealing with missing data. So let me answer that question first. So missing data, we don't try to impute missing data, right? So when we extract the data, we clean it, standardize it, and we rely on more than just the fields where the data is expected to be captured to identify certain aspects. So for example, if you're saying, well, my patient's a diabetic, but not everybody is recording the common problems in the same sheet, that's okay. So that would be considered missing data, but we have ways of determining otherwise the patients who are diabetic and identify that patient as diabetic. So in that sense, it is, but we rely on measures that have been validated. We don't impute data because that's the most likely thing. So I think the missing data is, we don't add data to the EMR. The missing data is mostly important when you do analyses, I guess, and regressions, and we can talk about imputing data then. But what we want to do is reflect what's in the EMR as accurately as possible. So we, but as Maddie was saying, when there's missing data, one of the things that the open reports have been helpful for is for people to actually clean their EMR data. So to identify where the gaps in their EMR, in their data recording is, and complete that. Yeah, so it's the purpose of open is to bring a community of like-minded practices to work together to towards sort of goals around their improving their practice. So we have tools that we can help you to support your efforts in quality improvement. We have a workbook, for example, for introducing QI in your practice, for carrying out a project. We're there, Maddie and I. Maddie's, thank you so much. It was a great presentation, Maddie. So we have all the standard QI tools, the fishbone and all these things. We're quite happy to orient you on that and support you in implementing this. We also want to, and we'd like to hear from you in terms of what you need, but we'd like to be able for you to rely on us to give you information. So not like the CPD that, Eric is doing, but somehow information on new tools for QI, new approaches. And we also do deliver actually some workshops on how to conduct quality improvement. Okay, the technical, do you want to talk about the technical team, Lisa's question, Maddie?
So right now we have 2 data managers that work with us to extract and do all the data processing. We're actually looking to centralize the data processing with Toronto. Toronto, they have a very developed quality improvement EMR processing team, and they've been doing it for many years now. So we're looking to join in with their group so that we can automate this process more and have the data come back to us in a timely fashion. Maybe Simone, you can talk about how sustainable is the funding for open?
You're right, Lise. It's it's a challenge, but a lot of it's automated, and we're not working alone, right? So there's 15, 14, depending on how you count them, networks. So we are one of 14 networks, and a lot of the development on the algorithms has been done over the past 10 years, and mostly supported through the Public Health Agency of Canada. So so what we're doing is applying them. We sometimes develop new algorithms to meet the requests of your requests, essentially. So that's quite an investment in time, but mostly what we do is apply existing algorithms. So in that sense, because we're really a large collaboration, it's sustainable, but we do need a constant source of revenue. So we're working on that.
Thank you very much, Simone, and thank you very much, Maddie, for a fabulous presentation. If you have any further questions or you have an interest in open, you can see here on the slide is the email address to get in touch with Maddie or Simone. So thanks again. This time, I'd like to introduce our second speaker of the day. This is Dr. Peter Tanuseputro. Peter completed his training as a public health and preventative medicine specialist at the University of Toronto. Peter is currently an assistant professor in the Division of Palliative Care, Department of Medicine. He's cross-appointed to family medicine. He practices family medicine in the community with a focus on palliative care home visits. His research focuses using linked health databases to explore healthcare and outcomes associated with aging and end of life in Ontario. He holds a PSI KT fellowship and a Tier 2 clinical research chair in palliative care and predictive analytics. So without further ado, Peter, I hand the reins over to you.
Thanks, Doug, and good morning, everyone. I hope everyone can see and hear me. I'm going to share my screen here. Sorry, I didn't get a chance to record my presentation, but and I apologize in advance if some of you have heard me talk about some of the data that I'll present today. But I've been asked to give an overview to the group about ICS, formerly known as the Institute of Clinical and Evaluative Sciences. Maddie touched on ICIS briefly. We're not supposed to call it ICIS anymore for obvious reasons. It's supposed to be ICES, just like IPM and BMW and KFC. Before I begin, just acknowledgement for the broader team. I think Doug is on the line, Doug Manuel. He's part of our Project Build Life and Respect team. I'm going to present some of the findings from the work that we collectively do as a team. An outline of the presentation. Again, I'm going to go over what we do have available to us at ICS. And, to make it really real and to make it really applied, I want to present some of our data, how we use the data at ICIS to conduct research in the area of palliative and end-of-life care. I'm also going to present a tool. So we don't only provide or produce health services research using ICIS data, but we use some of the data that we have available to us at ICIS to create tools to try to improve care. And I'll try to go over our Respect tool and what that looks like and why we've built it to try to improve the delivery of palliative and end-of-life care in Ontario. So an overview of ICIS. ICS is an independent non-for-profit corporation. It gets its core funding from Ministry of Health. So every year it gets some of money from the ministry to provide support for its infrastructure. The majority of funds that support ICIS though is grant funding. So scientists, investigators like myself, Simone, Doug, and others apply for grants, and those grants support the analysis that gets done at ICS on a cost recovery sort of basis. And some of that supports the overhead for ICS for it to continue to function. It does receive special designation under the Ontario Personal Health Information Protection Act, HIPAA. So it does have special designation so that it's able to collect data from other data custodians more easily. So one example of a data custodian is CIHI, the Canadian Institute for Health Information, and they contain or they collect data for hospitalizations, emergency visits, and so on. And even though CIHI collects it, ICIS forms agreements with CIHI to sort of assume or to collect that data and hold that data inside the repository at ICS. So ICS is mainly Ontario-based as well, so it provides data mainly for Ontarians across the healthcare sectors. Okay, so how is ICIS structured, or ICS structured? It's structured under 8 research programs: cancer, cardiovascular disease, chronic disease. There's a renal kidney group, life stages, which I belong to because I do a lot of work on palliative and end-of-life care. People doing research on maternal and child health are also in that life stages group. There's a mental health group, populations and public health group. I think Doug and others are might be in that group. And there's a it might be around, but there's a primary care. It used to be a primary care and population health. I'm probably missing something there, but Those are the 8 groups under which scientists are sort of organized. The typical entry, so there are more and more measures at ICS to try to improve data access to its holdings. Traditionally, it has been that, if you wanted to work with ICS, and in many cases, for residents, this is probably still the case, that the easiest entry to accessing ICS data is to work with someone, an ICS scientist who are familiar with the data. So in the Department of Family Medicine, I wrote down the names, I hope people don't mind, of some scientists in the Department of Family Medicine here who work with ICS data. So Claire Kendall, Lise Bieri, Doug Manuel, Amy Shu is a PhD health economic scientist, Simone, and others as well. I apologize for leaving people's names out, but essentially anyone in the AOS group who does research under Department of Family Medicine, I believe has touched ICS data at one point of time. Okay, what sort of data is available at ICS? The first set of data, is what we call health administrative database. It's data that is collected anytime anyone accesses services through basically their OHIP card. So anyone who has an OHIP card who accesses service in any of these sectors, whether you get admitted to hospital, you see your physician, you get visit the ER, enter nursing homes, medications, get home care from the LIN or formerly the LIN. All of that is collected and linked at the individual level. So again, for any of us who has an OHIP card, if we visit any of these sectors, or if we use our OHIP to access any of these services, that encounter is collected and linked and can be studied for research purposes. ICS has also a whole host of other data repositories. So registries, it has a cancer registry for all individuals diagnosed with cancer. We have access to the CIC immigration registry for all immigrants. We can identify who's an immigrant, who immigrated from outside of Canada since 1985, and information about where they immigrated from, immigration class, and so on. There's a registry called BORN, which is about maternal and child health, and information about that, quite detailed information. We do also have collected access to data that's collected through surveys. So the CCHS, the CLSA, that's available as well. And we have a whole host of other demographic variables from various sources. So what can we do with this data? Well, first of all, before I go to that, this is a snapshot of the ICS data dictionary, ICS data dictionary. So you can just Google data dictionary ICS, and it'll show you all the data holdings. So here's a list alphabetically. And if you click on any of these data sources, it'll show you all the variables that are collected under each of the databases. And I forget how many databases there are now, but over 60 plus databases that are at ICS and collected and linked at the individual level. So all of this data, the majority of it is linked at the individual level. So what do we do with that data? Well, we can look at a whole host of things. So we can look at, who our patients are and their characteristics. I mentioned some of them here. We can look at the healthcare use. So anytime, again, they access healthcare services, we actually collect that and measure that and can study that. We can look at, your typical exposures, whether that's interventions, drugs, risk factors that, we use to conduct studies. That's collected at ICS, data that, at ICS can be used to collect or identify exposures. And we look at outcomes, so survival, acute healthcare events, so things like MIs, hospitalizations for certain reasons, so on and so forth. Healthcare use can be an outcome in itself, transitions in care between care settings, decline in function. So we do have some information about people's function. So anyone who receives care from home care, formerly from the LIN or CCAC, and anyone who gets admitted to nursing homes, we have quite rich information about their function. And I'll show you some of that information later on. Okay, so instead of talking more in generalized about what ICS can do, I thought it might be useful to just show you, how we use the data and show you some of the ways that we use the data to conduct research. So I'm going to give everyone an overview of our program of research on end-of-life and palliative care. And I'm going to start with our initial first few studies, which essentially looked at an end-of-life approach for decedents and looked at the care that people are getting in the year prior to death. So we took a retrospective cohort approach. We explored all deaths that happened between fiscal year 2011 2013. Obviously, we've updated this data set since then. But we looked at in the first few studies a collection of 265,000 deaths, so quite a large number. And with that cohort, we looked at their healthcare use in the last 12 months of life. So again, this is a bit of an overview, but again, with ICS, we were able to look across all the healthcare sectors to identify, did they use healthcare in any of these sectors in their last year of life? So acute care, outpatient care, continuing care. And you can see there that is quite a comprehensive list, right, of healthcare services that are available to us that's publicly funded. All of this combined is about 85% of the healthcare budget of Ontario. So it does capture a majority of the healthcare services that are being provided. Things like public health administration is not covered, obviously, in this, but it's a majority of services that are provided in Ontario. So we can, using this, we can look at across sectors and again, like ask questions like what proportion of Ontarians dying use nursing homes or end up in a nursing home in the last year of life. Normally we have, I have this interactive and people have all sorts of answers. But if you can guess in your own head, what proportion of Ontarians do you think in their last year of life actually end up in a nursing home? And so that's, we don't not only look at nursing homes, obviously we look across health sectors, but these are sort of the sort of questions that we intuitively sort of kind of know what's happening. But I think using the ICES data is a really powerful data to really show what's happening. So this is the result. So here is long-term care. So this is decedents, the y-axis is decedents with at least one use in the last year of life. And you can see that 24% of Ontarians end up in a nursing home, admitted in a nursing home in the last year of life. You look at the other dominant sectors, you can tell that 83% end up in the ER before they die. About 70% when you add up people with end up in hospital with and without ICU will end up admitted in hospital in the last year of life. We look then further at costs. So there are something called macros at ICS where people have developed methods to extract outcomes using the data at ICS. And there's something called costing macro, so that for every healthcare use that's available at ICS, we're able to identify the costs associated with that healthcare use. So whether that's a physician encounter or hospital admission, that can be calculated. So here we wanted to look at the contribution of each of the sectors. And you can tell here in the last year of life, inpatient costs really dominate 43% of all healthcare costs in the last year of life. You can tell all the other sectors are quite significantly smaller. So what we found is that end-of-life care is expensive and hospital-centric. So we can identify and look at things longitudinally as well. So this is a graph of costs as death approaches. So for that 265,000 decedents, we quite easily and quite quickly can figure out the cost trajectory of these individuals as death approaches. So as you get closer and closer to the right here, you get closer and closer to death. And this is a total cost. I think hopefully you can see my cursor, but this total cost across health sectors. And you can see that it rises sort of consistently until the last 3-4 months where it really jumps up, right? And when we broke it down by the different healthcare sector, it's a red line here, acute care costs, which is hospital admissions and ER visits, which is really driving up the cost. All the other costs, we knew end-of-life care was expensive, but for the first time we showed that end-of-life care is expensive because of acute care and not other sectors. Excuse me. So again, in the last 3-4 months of life, we showed that that cost is really rising considerably. This was the front page, national page story that came out of it that showed that there was considerable interest in our study. That showed that there was considerable cost again at the end of life. So not only, obviously we want to not only show the sort of outcomes like cost and healthcare use in our populations, but we want to know, what can we do about it, right? So one of the things that we can do to try to improve healthcare use and healthcare costs is the delivery of care. And in this case, obviously in the end of life period, we explore the delivery of palliative care. So we asked, what proportion of the students will get a physician home visit in the last year of life. So in the same period where we explored these outcomes, we asked, what proportion of people are actually getting palliative care, and in the home setting where the majority of people want to spend their last days of life. So if you can sort of guess in your own head, what proportion of people will get a visit from any physician, right? Any physician, any one of us in the room, for example. The answer is actually about 20%. So we found out about 1 in 5 Ontarians dying will get some sort of home visit in the last year of life. So considerably less than what we thought was going to be optimal. Cancer patients get more care of that care, as we knew that a lot of the end-of-life care system that we provide in Ontario is cancer focused. And when we look across sectors, so in hospital, in the ER, home care, it tallied up to about 52%, or 1 in 2 will receive some sort of palliative care in the last year of life. So, this kind of speaks to some of the issues why we see that cost rising, even when death is sort of expected in the last 3 or 4 months of life. So does it matter when we provide these house calls? So we wanted to not only look at the delivery of care, but we wanted to see if it's effective. So these are decedents who have no visit, and 57% of them died in hospital if they get no visits in the last year of life. If you get a visit from a physician, but not palliative specialist, palliative care specialist, that number drops down to 41%. And if a palliative care specialist visits you, it's 35%. And I believe these are the adjusted numbers, adjusting for age, sex, multimorbidity, et cetera, et cetera. So it's obviously not about dying in the hospital, but we looked at the days in hospital as well. I'm not going to go through this in detail, but essentially the more visits you get, the less days in hospital that you spend. So if you get 5 or more visits, the number of days that you spend in hospital in the last 3 months of life goes down by about a week. Okay, and on average, Ontarians spend about 16 days in hospital, admitted in hospital in the last 3 months of life. So these are sort of some of the stories that came out of our study, just showing that most people want to die at home. Why is that not happening? Part of the reason is we think that the delivery of palliative care is lacking, especially in patients' homes. So we always comment, which color house do you live in? Because a lot of the care that we provide in life care and palliative care, especially in people's homes, we think are sort of random, right? In terms of, does your family physician do home visit? Did someone think about, your patient dying, or being close to end of life? Or, if they don't do home visits, was palliative care involved and asked to be involved? So some of that randomness, we're trying to fix by making systematic changes in how we identify people who are nearing the end of life, and trying to link those people to services as they get closer and closer to death. Again, partly to deflect that healthcare costs and healthcare use in the acute care setting. So I'm going to skip over this, but one of the ways that we try to help identification of people improving palliative and end-of-life care, and then I'm going to stop, is to create tools to identify people who might be approaching the end of life. And our philosophy, one of our philosophies is, imagine if WebMD was not the place where people went for health information. A lot of people, a lot of my patients, go to WebMD or just Google doctor, right? And just Google things for information. But a lot of the information is not customized to who they are. And so one of the premises of our Center for Individualized Health, which we've created here at Briere, is to create tools that help people make decisions based on who they are and what's going to happen to them. So our Respect tool here is one example, and I'm going to test drive it, and I'll show you how it can actually be used to improve care decisions and also the delivery of care. So our Respect tool essentially predicts survival. That's the outcome we're predicting here. And it uses data from the home care assessment that are conducted on a regular basis in Ontario. So in this assessment data, we have quite a number of information. So over 400 elements of 400 variables, including demographic information, caregiving, function, symptoms of health decline. And we use all of that to try to predict death. Okay, so we link home care data to death data, and then we could create prediction algorithms where if you provide your information, it'll predict your survival. And we do this using over a million assessments, home care assessments that have been conducted between 2007 and 2012. Okay, so I'm going to go through a case, go through the respect, and then call it a day. So this is a case, Mr. Johnson, 74-year-old electrician. He has multimorbidity, coronary heart disease, CHF, COPD. He's getting some help around the house from CCAC or from the LIN with meal prep, carrying around the house, and using the bathroom. His COPD is quite severe. He's on oxygen for a couple hours a day. He's visited the ER and been hospitalized once in the last 3 months of life. Physician wouldn't be surprised if he died in the next 6 months. He is quite advanced in his COPD, but he's just getting out of the hospital and he's looking forward to recovering and attending his weekly card game. So the question I always ask is, what is this person's prognosis? Maybe more importantly, should palliative care be involved? Should end-of-life care be involved at this stage? And for us, as clinicians, I think it's very difficult, or even for patients and families, it's very difficult to figure out what is this person's prognosis, given the complexity of how they're doing, their chronic conditions and their function. And so with respect, we hope we can automate that, use the big data, and to kind of give information back to people about their what's going to happen to them. So I see I have 7 minutes, so sorry, I'm just going to go through it very quickly. I'm going to hopefully be able to share the respect tool here, and then yeah, so I'm going to go through this fairly quickly, but let's pretend this was our patient, and we can enter information about this patient, and our respect tool will give us a prognosis. Okay, so I'm just going to put in that Mr. Johnson is 74. He's went to trade school. He has CHF. I think we said COPD, coronary heart disease. We said that we wouldn't be surprised if he died in the next 6 months. And now we start getting information, even before entering anything else, about this person's risk of death. So 3 month, 1 year, 5 year risk of death. And a metric that we find has been very helpful is life expectancy. So for people with the same responses, 2.3 years is how much this person has left to live. As someone who's frail receiving home care. So I'm just going to quickly put in more information. We say he needs help with meal prep and housekeeping. You can tell as we put information, the prognosis will change. We said, I think he had difficulty using the bathroom, getting around. We'll say he needs limited assistance. You can tell life expectancy goes down. We'll say that his ADLs have gotten a little bit worse since he's been hospitalized. You can tell life expectancy changes. I'm just going to put in oxygen here. So oxygen he's actually receiving and using. Now you can tell his prognosis is 8 months. And the last thing is, he's been hospitalized and been in the ER once in the last 3 months. So now, with this information, using the big data that we linked, risk factor information to outcome data like mortality, we're able to predict this person's life expectancy and give them a really good sense of also that range, right? So 25% of people die within 8 weeks, 25% people survive 1.9 years. So with a person with a life expectancy of 7 months, median life expectancy of 7 months, I think most of us would agree that palliative care should be involved. And again, like this tool provides concrete evidence, concrete, prognosis using, powerful, really huge data sources, right? To kind of, give the experience of that Ontarian with the same responses. So I'm going to stop there. Sorry, Maddie and Doug, for going a bit over, as always.
It's all right. Thank you so much, Peter. That was a great introduction to ICES data, examples of how you have used it. And thanks again for sharing the respect tool. I think it's going to generate quite a bit of discussion and interest. Just if we can turn to the chat, there are some questions that are really coming in here. I think where we get down to first one with Lise. She's asked, do you look at the urban-rural divide in accessing home palliative care?
Yeah, so what we've been finding is that home care actually, through CCAC and LINS in relatively rural areas, we're not talking about remote, but in rural areas, it's actually doing fine. We're actually delivering home care similarly to urban areas. Physician home visits, forget about it. There's no palliative care specialists that practice in rural settings. So we found that 98, 99% of palliative care specialists practices in urban settings. But us as what I call palliative care generalists, as family physicians who have the ability to provide end of life and palliative care, we're exploring whether or not there's differences in that delivery among generalists in urban rural settings. So that's one of our active projects, Lise.
Terrific, thank you. Gary Viner's asked, I wonder if there's a way of accessing the label of frailty and how and when it links to end of life.
Yeah, so that's a great question. And a lot of those variables, as you can tell, is related to frailty, right? Whether or not you can do your activities of daily living and instrumental activities of daily living. I think that's really key towards, this idea of frailty. A lot of the frailty indices do account for a lot of ADLs and IADLs in their frailty score. And what's interesting is that once we account for your age, your sex, and your ADLs and IADLs, things like chronic conditions don't really matter that much. So this idea, Doug Manuel always talks about the idea of senescence, and we've been finding that that as people senesce and get closer and closer to death, it really doesn't matter what you're dying of, but your function and your level of frailty is what really strongly predicts how close you are towards death. So that's one of the really strengths of Respect and the data that we use is that these people who are receiving home care, they get asked like 400 questions, right, about their health status, and not just chronic conditions. And we use that and link it to outcomes. And remember, we only link it to survival, but we can link it to other outcomes if you wanted to, right? Whether or not they end up in the ER, whether or not they end up in nursing homes, and frailty is predictive of all those outcomes we've been finding.
Thanks, Peter. Francis has asked a question about the specificity of the Respect tool.
Yeah, so in terms of I'm guessing in terms of our prediction estimates. So I don't think I have enough time to kind of describe, how we spit out the information, but we do provide ranges, right? And we focus that it's not about the median survival, but it's also about the range. So the IQR, so 75% of people survived past this time and 25% died before. And what, one of the things that I think a lot of people have been doing is that, okay, sure, my patient has all these characteristics, but, of people with these characteristics, I think he or she is more or less resilient than the average person. And, that sort of kind of clinical gestalt will get you an idea of whether or not that person might be closer to the 75th, the 50th, or the 25th percentile. But I think what Respect does is gives people, clinicians, families, caregivers information that's sort of black and white. No one has to guess. Clinicians often hesitate in trying to guess how much you have left to live because we get it wrong all the time, right? But now you don't have to guess. This is the average experience of people just like you using the big data at ICS. This is what your survival looks like for the average person. You might beat it, you might not, you might be worse off or better off, but this is the average experience.
Okay, thank you, Peter. So Ed's made a comment here. Did big data just prove that an assessment by an experienced family doc is pretty accurate?
Yeah, I mean, the one thing, Doug, that, I think a lot of us, obviously have, good clinical acumen that we've built up over the years. I think the one thing that we've recognized is that patients are getting more and more complex. And, sure, terminal cancer, if you have terminal stage 4 cancer, we know sort of your prognosis. But if you're talking about frailty, Alzheimer's, organ failure, multimorbidity, it's getting harder and harder for us to assess. And again, a lot of the power of using big data like ICS is that we don't have to crunch it all in our head. The data will do that and look at interactions between factors and look at how they interplay with each other to kind of predict outcomes, right?
Yeah. Well, thank you, Peter. I think we're right at 9 o'clock now. I'd like to thank you for your presentation and thank you everyone for your engagement today. Let's look ahead. We have two things I want to address. One is that if you can spend a few minutes before you leave today, just filling in the evaluation, that would be terrific. Maddie's put it here in the chat. And also, please spread the word. Grand rounds will be next month's edition will be on the 26th. And we're going to have a presentation by the Pembroke Family Medicine Teaching Unit. So please tune in for next month. Thank you all for joining. And as I said, please fill in your evaluations before you leave today. That would be great. Thanks again to our presenters.